Welcome. How many of you folks have been to MEDS Ed before? Give me a call sign there. How many folks, is this your very first one? Well, welcome. We do MEDS Ed here at CareOregon, sponsored from the pharmacy department, about every other month. Different topics as diverse as chronic health conditions to motivational interviewing. So you'll find that this is an ongoing program, and we're going to continue it through in 2019. So lots of good stuff there for you. Here's a snapshot of where we're going to be covering today in terms of our agenda. There will be a couple of breaks, but we have a lot of content, so we're going to try to keep moving as briskly as we can to make sure to include it all. And this is a snapshot of all the different learning objectives that we'll be covering as well. Without a question, I think if you look at the audience in here today and you see how many of us have showed up for this event, you realize that for quite some time we've been in the middle of what you have to call a crisis, right? Pretty no argument there. I think realistically you could say that it's a catastrophe, that it's a disaster that's still going on. And one of the things that's interesting to look at is how we respond as a society when a catastrophe is going on, and how we look at people in the midst of a catastrophe, depending on what kind of outbreak it is. That's one of the things we hope to look at today, is not just how to effectively manage the conditions of people who are grappling with substance use, but also how we look at them and how we treat them is equally important. How many folks remember about a year ago, September, Eagle Creek fire, forest fire that we had in the Columbia Gorge? Everyone, I think, has that pretty indelibly seared into our memories, right? 50,000 acres scorched in a very short amount of time. Catastrophe? Yeah, I think so. I think without question. But I don't remember at the time anybody saying, you know, I just don't feel that water should be used in that way when a fire breaks out. I just don't agree with that. I don't believe in it. Or that if there's a fire like that, you know, we're going to do our best. But if the fire's not out in 48 hours, I think we're going to stop trying. That doesn't happen either. And I don't remember anybody saying, you know, water's just for trees who just can't stop burning any other way. So why would we look at trees and forests differently than we look at human beings? Just one question I think we should keep in the back of our minds as we go through our content today. So some things to think about. Will be throughout our presentation trying to get your thoughts on similar questions here today. You can join Poll Everywhere by texting my name, 518, to the number 22333. You'll be plugged in there, and then you'll be live for various polling questions throughout the segment. So enough of me. I think we should move on to our presenters and get started, if that sounds good to everyone here. To begin, we are fortunate today to have Dr. Paul Lewis with us. He's a hospital-based pediatrician at OHSU and the Multnomah County Health Officer. In his public health role, he follows longtime health officer Gary Oxman in promoting overdose prevention, recovery, stigma reduction, and upstream elimination of risk factors in substance use disorder. He lives in Portland with his wife, Ann Scott, 3 daughters, dogs, cats, and pantry moths. A lot of interesting things going on there, Paul. Please give a warm welcome to Dr. Paul Lewis. Thank you, Paul.
I trust this is on?
Yes.
Okay, good. I'm a pediatrician by training. I'm not, I don't know very much from the clinical aspects about substance use disorder. The role of the county health officer is whatever I want it to be. And as Paul Carson said, this is a sort of a pervasive, troubling, society-wide a problem. But a couple of background things. One that I always try to address at the absolute front end is that over the decades, probably pushing 100 years, there's been a lot of United States drug policy, some of which is not very thinly decised racist policy. And I think that's something that really needs to be acknowledged. A lot of effort is going into the current issue, which people are talking about as the opioid epidemic. I'm going to provide some information for you that will hopefully illustrate the breadth of that problem. But there's a real concern among communities of color that this particular problem is getting a different kind of attention than previous drug epidemics, which have largely been dealt with through mass incarceration. The other thing is that even though we're talking about opioids, there's a lot of substances that are misused. And I'm going to show you some information later. As I like to say, we probably buy got more business from the funeral directors from alcohol than from illegal drugs. That being said, the underlying biologic factors for substance use disorder are actually quite similar across substance use disorders in general. A lot of you in behavioral health, I think, probably know that intuitively or academically. And then here in the Portland metro area, I think there's a very complicated relationship between substance use disorder, mental health disorders, and housing. And I don't have a theory or answer for how that is. I just decided it's complicated. Tiny bit of I love trying to figure out what opiates are, how far they go back. This is a highly pregnant opioid poppy oozing with resin, which contains directly in that resin both morphine and codeine. They're part of that resin. And then people think the Babylonians used opium. This is a relatively direct reference in the Odyssey to the use not only of not just the use of opiate, but of opiates plus alcohol, right? That you put the drug in the wine to really put those miserable memories away from you. Lots of curves, all going the wrong direction. This one's actually pretty complicated. There's a lot going on it. This one's intended to illustrate the more recent issue with drugs like fentanyl and its friends going up more steeply than the curves for heroin and prescription opioids. But down in the green and the red, we have stimulants. Again, when we look at our deaths, more and more are not attributable to a single substance, but to multiple substances. What's going on? A lot of things are going on. A really disturbing report came across my desk 2 days ago from the United Nations about the dramatic increases in production of all psychoactive substances and illegal distribution. And they feel, those authors felt that there was a transition from a demand-driven epidemic where people are trying to get to the drugs to a supply-driven epidemic where there's so much drugs out there that everyone risks being exposed. And I'm going to make a couple of points. Again, this audience is probably more versed in it than I about human susceptibility to intoxicants in general and to opioids in particular. We know that it's not hard to lose tolerance, and that the drugs have what we call a fairly narrow therapeutic window. A little is good, and a little more is too much, and can be fatal. The concept that I've found a lot of traction for in recent years about talking to audiences in general, maybe not this one, about opioid use disorder as a chronic disease. It's really helped, I think, move a lot of people from other sectors toward a more compassionate view of substance use disorder in general. And then, of course, I think the underlying causes are things that we're not doing a very good job of addressing, such as social conditions, childhood trauma, et cetera. It's pretty easy to go from opium poppies to black tar heroin, which is the most popular kind of heroin around here. And it's relatively cheap. Is there anyone from law enforcement in the audience? Okay, so I can make a little fun of them. They're not health providers, so they make some estimates. So I asked, well, how much does it cost? And they say, well, you can get one of these little broken balloons for about $100, and that's about a gram. You use about 1/10 of a gram at a time, so about $10 a dose. if you do the medical math, that would be a huge dose, but again, often these things are cut. So, but anyway, that's an estimate. The point is it's relatively in a, latte, fancy latte cost thing. And the other thing is the medical piece for those who don't do physical health is that heroin, if you're using it regularly, you need to use it about 3 times a day, right? It's not a once a day thing, it's a couple of times a day thing. About 30% of the world's opium poppy production actually goes to pharmaceutical companies. And sometimes they do stuff to it in the orange arrow, which means they modify it a little bit. In the blue arrow, that's your codeine and morphine. They basically just clean it up, and they can turn that into pills. Legal and illegal chemists can make what we call synthetic opiates, fentanyl being one example of that, without having to use opium poppy at all. This can be, wherever, well hidden. And the main thing that's going on now is that it's mostly showing up not as sort of a white powder, but as something that looks like a legitimate pain pill but has no relationship to a legitimate pain pill. And this, according to my law enforcement friends, is arguably even cheaper. And again, those who know about the potency of fentanyl will question the numbers, but again, relatively easy to cut with the things that you make pills out of. So you're not, a gram of this pill is not really a gram of the drug. So there's a lot of stuff out there, and it's pretty easy to take what we would consider to be legitimate pharmaceutical use and produce things for illicit use. These are real pictures of real things seized in our area from the state crime lab, and they all are meant to look like oxycodone, and none of them are oxycodone. One just has alprazolam plus one of the fentanyl analogs. Other ones have 3 different opioids in them, et cetera. And my punchline from this summer is I asked, well, what fraction of the pills that are getting tested are not what they appear to be? And it usually, you go, well, maybe 20, 30, about 100%. So pills on the street are not what they appear to be. And full stop, that's it. So it may have opiate in it, but the dose, the actual opiate, who the hell knows, right? It's fake news, it's fake pills. You don't know what it is. And this is a danger, right? Because if they were diverted pills that were the real thing, the person using it would know what it was and would know how much it is. That appears in our area to no longer be true. So I find it very disturbing that as we counsel people, the counsel is you don't know what you're getting. And these things, the chemists, when they look at them, they can't tell the fake from the real. The color's right, the size is right, the shape is right, the imprint is right. So again, news you can use. Okay, so again, some pretty general stuff, obviously going to be below some folks, but the real point from the medical perspective about opiates is that as the dose increases, the effect changes very dramatically, where these are critical medicines, they're on the WHO essential medicine list for pain control. But higher doses lead to other effects, including euphoria, which quickly then turns to the sleep that Homer was talking about in the Iliad, that you basically go into a stupor or coma and then don't even breathe. And death can follow relatively quickly after that, especially when the potency of the drug is unknown. Anyone here not familiar with Narcan? Good. It's good. It's really downstream, right? It can bring you back from the edge of death, but at that point, it's a prevention opportunity, but it's a prevention at the very, very end of the chain. The other issue with chronic use of opiates is that the body develops tolerance relatively quickly, and a larger dose is needed over time to get the effect. And you've probably heard the stories more than I have about how over time there isn't even a lot of pleasure associated with the dose. It's more about keeping withdrawal at bay. And withdrawal is a physical condition related to having developed a tolerance to a drug, and the body reacts to not having that with a miserable illness described as being, worse than the flu, with just physically reacting all over the body with nausea, vomiting, diarrhea, muscle aches, etc. And that the drive to avoid this is very, very strong. If you're having withdrawal, the options you have, or as my Gary Oxman always taught me, the choices you make are the choices you have. Your choices are not that great. You can use the drug again and again. With a drug like heroin, it's a couple of times a day. Try to get through without any kind of treatment. There are medicines that can be used for symptomatic treatment, or we would hope that if people are interested in recovery, they could actually not only have their withdrawal managed with effective medication, but also use medication to help them enter and stay into recovery. So this is a picture I stole from, I think it was the Surgeon General's report on addiction in America. Again, there's a lot of behavioral health folks in here. I'm not going to embarrass myself by going through the psychology of this, but the idea is that there's a cycle with opioid use disorder, which includes a couple of things happening in primitive parts of the brain that include both the pleasure from the drug in blue, the relief from the negative consequences in red, and then the more conscious brain thinking about how to either feel better or not feel bad, driving the cycle. Thinking about risk factors for opioid use disorder, there are some things that I call fixed here. Males seem to get into trouble more than females, as is typical with almost all behavioral problems in my observation. Youth being more susceptible than older folks, although when we look at the age graphs, we'll see that not a great deal of discrimination by age. And then there are biologic factors that probably put some people at greater risk than others. There are other things, however, that I try to think about is what is things we can do something about, what's potentially changeable. And they're mostly social factors about how we treat one another and how we construct our society, with a particular emphasis on adverse childhood experiences. Is anyone not familiar with the concept of adverse childhood experiences? Right? Who's familiar with the concept of adverse childhood experiences? All right, pretty strong representation there. So what are the adverse childhood experiences? There's abuse, neglect, and environmental factors. For research purposes, you can kind of come up with a score. I suspect those of you who are familiar that have thought about your own lives and where you rank on that. And it turns out to be a pretty powerful predictor of a lot of things. I do want to point out here that ACEs are not destiny. And again, we always think about risk and protective factors. And people are going to have ACEs. We'd like there to be fewer ACEs, but we'd also like to increase those resilience factors. ACEs are powerful predictors not only of health outcomes, those are on the lower part of this graphic, but also for behavioral factors. And when you look at different groups, strata of ACE scores, if you compare the lowest ACE scores to even a moderate ACE score of 4, there's a 6 times higher risk of alcohol use disorder and a 10-fold increased risk of opioid use disorder. And there's an epidemiologic term called attributable risk percent, which says, yeah, it's a big risk factor, but how much does it affect the people we're seeing? And it's probably around 50% of opioid use disorder we can tie back to adverse childhood experience. So again, to me, this is a huge, huge issue. People have tried to speculate on how adverse childhood experiences affect behavior and physical health outcomes. This is something from the AAP on the adverse childhood experiences at the bottom, leading to early childhood neurodevelopmental issues, subsequent social issues, risk factor issues, et cetera, leading to, on the top of the pyramid, to disease and ultimately early death. And again, this is one of my favorite quotes. I have it on the wall in my office. And of course, as a pediatrician, it really resonates with me that it's much easier to build strong children than it is to repair broken men. So how are we doing locally? I'm going to tell you a little bit about deaths here. It's mixed kind of news. Talk a little bit about the age, and then address the racial ethnic issue. So this is our local data. It's directly from our medical examiner. It's for all 3 counties. And if we look at all opioid-related deaths, our peak was actually in 2011. Holy cow. And things came down around 2013. We think that steeper drop that's the year that lead naloxone became available. And the day it became available, our neighbors a few blocks from here at Outside In were training and distributing it. And between Multnomah County and Outside In, more than 6,000 people have been trained since 2013, and more than 4,000 overdose reversals have been reported. So again, it's a big effort. I'd like to think it's helping to keep the lid on things. You remember the graph I showed you about the national graph. The national graphs are heading steeply north. From 2010 to 2015, only one state had a lower death rate in 2015 compared to 2010. It was Oregon. Right? So again, I don't consider flat to be success. This is 3 to 4 times higher than the death rate in 1999. Right? So this is still an F, but it's not as bad an F as everybody else. The other thing, if you stare at the graph really carefully for 2017, the blue is the fentanyl-associated deaths. It went from 15 to 45 in 1 year. We're on track to be similar this year, but the purple line didn't go up as much, and that's because, as I alluded to before, we're having a lot of deaths that have multiple drugs on board. When we break it down by this, you have to sort of hold in your head that the individual drugs you can have more than one individual drug in one person. This is based on a slightly different data source, but it's basically comes from the same source ultimately. This is from the final National Center for Health Statistics numbers on deaths. And these are death rates. So that was number of deaths, total numbers. We're pushing 200. Unfortunately, I think we're going to be closer to 200 than 180 this year. These are rates. So here you divide by the number of people in the population. This shows about a 2-to-1 ratio higher death rate for males compared with females. The age distribution there shows that the highest rate is in sort of the midlife period, but it's not that much lower in the younger seniors and younger age groups as well. And then the final thing, horizontal graphs, are the race ethnicity there. And again, I think the point here that you don't realize if you just look at the total numbers is that our actually highest rate of death is in Native Americans and Alaska Natives, which are 1.5 times higher than the white rate. And then the other thing about it only being white a problem is that again, it's a biologic problem. It doesn't discriminate, and the rate in African Americans is a little bit lower than the white rate, but it's 10 and 8 are basically quite similar numbers. So again, this illustrates that everyone is susceptible. It also illustrates, I think, the importance of when providing services that they are in the appropriate cultural context for the people most affected. Some people may have heard in Ohio and West Virginia there have been actual outbreaks of death and overdose where they'll have 100 overdoses in 24 hours. We're not super ready for that. We don't really have capacity for that, so we're pretty worried. So for about a year now, we've been doing what we call real-time surveillance of overdoses. This is a busy graph. We post this every week on our website. We convene ad hoc probably 12 to 20 times a year with the folks at law enforcement and syringe exchange and EMS and emergency departments when we have these what look like potential spikes either of EMS calls or emergency department visits. Fortunately, since early summer, things have been a little bit quieter, but again, only a few hundred miles to the north in Vancouver, they have almost 10 times as many deaths as we do, and the predominant drug there is fentanyl. That could happen to us tomorrow. Right now, we still seem to have a quite stable supply of heroin, and again, we sort of have a lid on things, but I have no confidence that will continue. So we're trying to have this as our early warning system so that we could respond effectively if there were a cluster. I don't want to be all downer. There is some goodish news around prescribing about the chronic disease model and knowing, as many of you do, that a lot of patients need treatment. Prescribing has been going down for a couple years. The total decrease since sort of the flat line in 2014-15 is about 30%. So again, I think the good news is that there's more appropriate use of opioids in the physical health setting. I think there are some unintended consequences in that that in some ways was a reliable, safe, believable source of opioids for some people, and the alternatives, as I illustrated to you, are not safe and not reliable. We are still prescribing a lot, though. Those were rates, but I'm not very good at math. This is every quarter about 120,000 people in our area get an opiate prescription. That's a lot of opiates, and it's probably 4 or 5 times higher than it was again in the year 2000. And again, we're not that much sicker than we were 15 or 20 years ago. The chronic disease model, again, got a huge amount of traction with this with various sectors about that humans are susceptible, recovery is possible, there's evidence-based treatment. And then I think this meeting being a good example of really trying to pull together the physical and behavioral health components to work effectively together. I put this together for another group thinking, well, where are all these people? Well, I don't know where all of them are, but some of them do show up. A lot of folks show up at detox. A lot of folks show up at emergency departments. And then just in Multnomah County alone, we probably have, I think it's more like 12,000 a year people come through booking with substance use disorder, and the most frequent one is opioid use disorder. So there's a lot of opportunities for people to get treatment. Another way of estimating it is from telephone surveys asking people, do you use drugs non-medically, et cetera. And by various estimates that it's quadruple figures, 20, 30,000 folks in need of treatment. And the surveys also show that about 10% only of the people who have opioid use disorder have received any kind of treatment in the last 12 months. So it feels like a big yawning gap that we're going to try to help fill today. This is not what I thought my slide was going to look like. But anyway, I think I'm done. I think there's a lot of, the human condition includes susceptibility to intoxicants. The opiate use disorder, I think, is particularly tenacious because of the severe withdrawal and the easy develop of tolerance. I think considering it as a chronic medical condition, I feel like there was another chronic, maybe there's a slide missing, but I think we found a lot of traction with different audiences in talking about how we treat diabetes or asthma or hypertension as something that needs ongoing treatment throughout life. That medication is valuable, and that as a chronic condition, there's going to be good times and bad times. Diabetics don't always have their blood sugar under control. Hypertensive don't always have their goal blood pressure, and that with substance use disorders and opioid use disorders, we need to have that kind of attitude as opposed to clean, dirty, failure, success, that we're trying to do better with these things. And then again, the stuff I'm spending a lot of time thinking about is working as far upstream as possible to prevent the next generation from having the same kind of problem. So thanks for your attention.